to give the top 10 case reports of the year, and they really were amazing. I don't know, how many case reports did we get this year? Dominic, how many case reports? Too many.
Too many.
Like the stars. Some were just phenomenal. And so I hope you enjoy, I'm just going to go through this real quickly, and I hope you enjoy this as much as I enjoyed putting it together. These are my disclosures. Start off simple and cute. This came from Baylor Dallas and Minneapolis Heart. It's a 25-year-old non-STEMI who was taken to the cardiac catheterization laboratory, and they put a 3.5 DES in, and it ruptured at 28 atmospheres, and they were stuck. They could neither get the balloon back, nor could they dilate it, nor could they go around it. So they got very clever, and they put a 3.5 non-compliant blocking balloon in, and then you can see how they were able to retrieve the balloon, and then they started off with a 1 millimeter balloon, then a 2 millimeter balloon, then eventually went up to a 3.5 NC and dilated the circumflex, and this patient did exceptionally well, had immediate symptomatic relief, and at follow-up did spectacular. I thought this was very clever, very creative. And speaking of creative, no one is more creative than our Dean Kariakis. He gives us one of 6 first-in-human experiences, compassionate use of J-valve for the treatment of a 43-year-old who had continuous flow LVAD-related aortic insufficiency. Multiple recurrent heart failure admissions, was a screen fail for the ALIGN trial, and then offered him compassionate use with the JC Medical J-valve. CT showed appropriate leaflet anatomy. And, you know, he asked the question in the manuscript, you know, what is the management strategy for continuous flow LVAD disuse aortic insufficiency? It's got a high incidence at 1 year, suboptimal surgical candidate because they're so sick, high mortality, and current transcatheter heart valves have a class 3 harm indication for this. So very clever use of the J valve in this. Patient had a heart mate in, and this is the final result, and this patient had immediate symptomatic improvement and resolution of heart failure. Dean, beautiful, beautiful demonstration and very creative case. From Ethan Korngold, we had a 45-year-old radial-based STEMI PCI, and this weekend warrior, 3 days after discharge, decided to resume his strenuous weightlifting program. And he presented with pain and swelling at the left radial access site. He had a mass, a throbbing mass, a pulsatile mass. This was at 4 weeks. You can see the duplex and Doppler studies. And then look at the surgical exposure. This is beautiful. And then he gave us a beautiful demonstration of the anatomy surrounding the resection. I thought this was a beautiful demonstration of a pseudoaneurysm at a radial access site. Another first in man, or first in human, came from Gilbert Tang, and a 74-year-old Jehovah's Witness who had bicuspid aortic stenosis and a bad cardiomyopathy, underwent TAVR with a 34-millimeter core valve, and 5 years later came back with severe structural valve deterioration, aortic stenosis, and an EF of 20%. CT showed anatomic features that did not allow them to do a valve-in-valve TAVR or leaflet modification. A number of things worked against them, and the patient was a horrible surgical candidate, so they decided to do a palliative valvuloplasty with Impella and Sentinel. Now, this has been talked about, but this was the first publication that I saw formally in the literature. They performed a coronary preservation technique with a wire in a balloon in the right coronary artery, did a valvuloplasty, got excellent hemodynamics, excellent symptomatic relief, resolution of heart failure, and this patient did well at intermediate term follow-up. Sarah Kahn from Corwell, you know, this I thought was quick. I thought these people were very quick on their feet. TEE is used for congenital pediatric cases, but with complications. This 3-month-old had multiple congenital abnormalities, had a previous Damas K. Stanzel anastomosis, mitral repair, Saner shunt, etc. Patient was coming back for a valvuloplasty and an aortic angioplasty. They placed the TEE probe, and the patient had hemodynamic collapse. Immediately and very intelligently, they did an aortogram, and you can see what happened. They had complete compression of the aorta. And what I thought was so novel and so unique about this happens 0.6% of the time, and they thought about it right away and did an aortogram, and you can see that they had complete compression of the aorta, pulled this back, and the patient recovered, and they went on to do their procedure. Another first-in-human experience from Sripal, who always comes up with something clever. A 59-year-old Jehovah's Witness came to the emergency room with an NSTEMI. He had multiple previous interventions, multiple layers of metal in both the LAD and the left circumflex, critical disease in the LAD, and a 360-degree arc of calcification on advanced imaging. So they initially tried balloons, and then they tried a cutting balloon, a 4-0 cutting balloon, and that didn't work. And then they tried a non-compliant balloon, and by angio and IVUS, they couldn't get the lesion to yield. So they did what was called a buddy balloon intravascular lithotripsy technique, and he even gave us a formula, a mathematical formula, on how to decide on the sizes. And he used a 4-0 shock wave and a 3.5 NC balloon, and after 80 pulses, they were able to dilate this, and then went on to a 5 millimeter NC and a 6 millimeter NC, and this patient had symptomatic benefit and is doing well on follow-up. Another first-in-human came from Scottsdale, Chintan Patel. I thought this was very creative. A 58-year-old who has this ugly aneurysm in the circumflex, failed multiple therapies, multiple PCIs, had 3 STEMIs in the course of 6 months or so, and even went to bypass and failed bypass. I know when we see these in our practice, we kind of shake our head and say, what am I going to do? This was an ugly looking aneurysm in the circumflex. He got very creative and decided to use what's called a cerebral flow diverting stent, or FDS system. It's a 64 wire cobalt chromium braided stent that works in cerebral aneurysms. This was the first time this had been attempted in a coronary vessel. This is the day of implant, and you can see at 7-week follow-up a pristine result, both sonographically and angiographically. I thought this was a terrific case, very creative, and worthy of mentioning in this session. Another first-in-human came from Ziad. And if you haven't seen these images, you have to. I don't think anybody has advanced our understanding of high-def imaging or the identification of vulnerable plaque quite like Ziad. And he used deep OCT NIRS, optical coherence tomography and near-infrared spectroscopy in 25 patients with the SpectraWave system. These are phenomenal images, and he demonstrated that compared to standard OCT, there's greater depth of penetration, greater visualization of the vessel, increased resolution to interpret the pathobiology, vascular pathobiology, and NIRS identification of lipid-containing plaque. He's going to go into greater depth, and I went through that fast because he's going to go into greater depth. This was a unique case out of Buffalo, a 77-year-old woman with a history of mitral repair with an A2P2 alveoli stitch and a 30-millimeter physio ring, presented with congestive heart failure, a 45% EF, and severe mitral regurgitation. The game plan was a 26-millimeter Sapien. CT anatomy was adequate, a good neo-LVOT, but the heart team said we got to do something with this alveoli stitch, so they opted for electrosurgical laceration. You can see up here your alveoli stitch. They put in a 20 Gore, 2 steerable Agilis catheters, Judkins guides, formed their Estado flying V, electrified it, and then lacerated it. Here's your flying V and your laceration. Put a 26 valve in, and there was immediate and sustained hemodynamic improvement in this patient, and this patient's symptoms resolved and is doing well at follow-up. But the winner of the most unique case, I think Jamie McCabe is a little bit of a mad scientist. Some of the things he's done, and I've had a chance to work in our lab with Jamie multiple times, it's amazing the stuff that he comes up with on the fly. This was a surgical mitral replacement with severe PVL at an outside hospital for staph endocarditis, complicated by hemodynamic instability, renal failure, dialysis, etc., multiple recurring episodes of flash pulmonary edema, and a large PVL with severe hemolysis. At the outside hospital, they tried VSD occluders, which did not work. So they sent him to Jamie. And so Jamie figured, I'm going to pull the VSD occluders out. Well, they got the one out, and then the other one sort of spontaneously came out. So that was jumping around on TEE and angiography. So they tried a couple of ASD occluders. That didn't work out so well either because well, they had to fetch the VSD occluder out of the PA, and even with the ASD occluders in, which looks like a jumbled mess, they still had severe, severe leakage around the valve. So they tried a number of things, and it reminded me when I was 12 years old and we wanted to see how many people we could fit in a Volkswagen. It's a jumbled mess. So finally, what he did is he decided to put a 31 Watchman in. But you know, the fabric cap is permeable. So he still had leak through the device. So only as Jamie could do, he decided to put 2 penumbra coils in the center of this and ameliorated the paravalvular leak. I don't know where he comes up with this stuff. I really don't. But this was my choice for case report of the year. And within 5 days, CHF resolved, the hemolysis resolved, and at 2-week follow-up, there was little, if any, PVL. So I hope you enjoyed watching these cases as much as I've enjoyed reviewing these cases and putting this case report section together. And thank you very much for giving me the opportunity.